Hello, everyone. Happy Friday. Welcome to our Pull Up a Seat. Please let us know where you're zooming in from. Write it in the chat, and we'll get started shortly. So we'll just give everyone about 2 to 3 more minutes to join us, and then we'll get started. Okay. Alrighty. So again, happy Friday to everyone. Welcome. My name is Shonda Cooper. I am a Senior Program Director here at Tigerlily Foundation. We are so delighted to have each and every one of you joining us this morning to discuss biomarker testing. We have a great lineup for you today. Very excited for you all to come and be a part of this conversation. Pull Up a Seat is a space where we shine a light on the experiences of Black women with breast cancer, and we really look at how we can move towards transformation and change within that space. So just a little run of show and agenda for today. I have done a welcome. I will be doing introductions of our phenomenal panel, and then we will also, I'll share about the 5 agreements as it relates to this space, and then we'll be hearing from Dr. Henderson, who will be presenting on biomarker testing, as well as after that, we have a special treat as well, Dr. Nizar Bhulani, who will be sharing a presentation from Dana-Farber. And then we'll be hearing from our phenomenal patient experts, hearing their stories. We have ladies that are coming from Houston and Charlotte that will be sharing about their journeys, as well as how that relates to the topic of biomarker testing and genetic testing within their families, within their own journey, and what they'd like to see moving forward. And then we will open it up to you, phenomenal audience, to be able to share and interact. This is a space for us to, let loose, write in the chat as we're going through. If there are questions, comments, this is definitely a space where you can do that right in there. We invite you to engage as an interactive conversation. So after you hear all this information and rich content, we want to be able to then talk about it. So we invite you to do that, and then we will be wrapping up with closing remarks. And this will also be, since it is recorded, we will be sharing this on our YouTube channel within the next few days, probably on Monday, since it's Friday. All right, 5 agreements. So how to be in conversation. We ask that you monitor your airtime, speak your truth, speak from your own experience, always lead with curiosity, not judgment, and most importantly, please keep this space safe. Our why. Why are we here? Why do we do this work? Tigerlily Foundation was founded over 17 years ago by our founder, Mema Carmo, who was a triple negative breast cancer survivor. Our mission is to educate, advocate, and empower young women before, during, and after breast cancer. We envision a space of future where breast cancer diagnosis does not inspire fear, but it ignites hope for a future. And through our Angel Advocacy Patient Program, we help to equip our Patient advocates, we help to equip those within our community to be force multipliers, to be able to be voices and share about, educate their community, be able to amplify their own voices and their stories to make a difference in the world. So we help to be a conduit to that through our work. We also do it to honor those of our advocates and those who are angels who are not physically with us no anymore, such as Shantae Randall, but we continue the work that they started and continuing to their legacy through our work. So pull up a seat. What is pull up a seat? Pull up a seat is usually it's a conversation where it's co-hosted by Black and Brown patient experts and a medical health professional to amplify the voices of Black men and women through candid conversations on topics ranging from racism in clinical trials to biomarker testing to unequal healthcare treatment through different stages of breast cancer. We touch it all, talking about environmental challenges, all of those different gambits across the spectrum. So I'm going to stop sharing my screen now. And I wanted to also, as I mentioned, I'd like to present and invite, and we will have introductions where I will showcase and share our incredible patient experts. We have Lashelle Scott on, who is from Houston, who will be sharing her story, Brooklyn Cobb, also from Houston, and Shardell Artis, who will be sharing she is currently in Charlotte, sharing their journeys. Before we dive into that, I would like to introduce and welcome Dr. Henry Henderson III, who is a trained cancer biologist and cancer health disparities advocate. He has received his BS from Southern University and A&M College and his PhD in integrative biosciences with a concentration in cancer biology from Tuskegee University. He also has completed his postdoctoral work training at Vanderbilt University Medical Center, and he currently is a medical science liaison at Foundation Medicine. He's a proud member of the American Association for Cancer Research and American Society of Clinical Oncology. Henry is also the co-founder and director of Cancer Awareness for Black in Cancer, which is an organization aimed to increase representation in cancer-related fields. Dr. Henry Henderson, welcome, and we are so excited to have you here. I'm going to pass it over to you to tell us more about biomarker testing. So welcome.
Thank you, Shonda, and welcome everyone to the talk. I'm really excited to get to present on this really important conversation is biomarker testing. So I'm going to share my screen, and Shonda, please let me know if it's actually being shared. You know, sometimes the Zoom and technical issues. Are you able to see my slides?
It is. It's loading. Okay. Yes, okay. We can see it now. Yep.
Okay. Good.
We are good.
Let me make sure it's over here. Perfect. All right. So today we're going to talk about biomarker testing. So there's a lot of science. As a scientist, as a cancer biologist, I don't like to speak super sciencey to my family because sometimes they have no idea what I'm talking about. So I like to bring it all the way down to the fact that where my 10-year-old nephew can understand it, right? So if I can explain to my nephew and he can speak it back to me, then I know I've done my job. So at any time throughout the talk, if you want to know what something means, pop it in the chat and I'll address it. I can't see the chat right now, but Shonda will go through the questions after. But let's dive into it. So let's go to the level set. You know, a lot of people are joining the call and may not know this. This is maybe information that you already know. But in the U.S., breast cancer continues to be the most common cancer. We know that for white women, they get it more, so that the incidence is higher in Caucasian women. But the caveat to that is that Black women die at a higher rate, right? So even though Black women have a 4% lower incidence rate of breast cancer, they have a 40% higher chance of dying from that. And so that's really important. And that could be to a lot of things. And what we're seeing now, although we can't really pinpoint the concrete evidence, is that we know that biology is playing a role in this difference. And so when we think about death rates, when we think about incidence, you know, how do we find the differences between those cancers to actually make an impact? And that's where biomarkers come in. So what exactly is a biomarker, right? So I told you I like to kind of break the science down so that everyone can kind of understand it. A biomarker is a molecule found in the blood, and other body fluids, or even tissue.
Sorry, we can't see the slide. What is the biomarker slide?
Oh no, let's see. Let me stop and reshare.
Okay. Okay, we see the after diagnosis. So I
Let me go
think,
back.
okay.
All right, you should be able to see it now, right?
No, it's still showing the after a diagnosis slide. Gotta love Zoom. So we're gonna try it again. These things happen in this virtual space. Yes, we are so excited to continue to hear what you're sharing about the what biomarker testing and
Yeah,
everything.
let me see that. Yeah, I don't know what's going on, but we'll try it again.
Okay, let's give it a try. Oh, there we go. All right, biomarker
Okay,
testing. Yes,
okay, let's
we see
see.
it. Yep, got
Can
it.
you see me moving the thing
Yes,
now?
yes.
Okay,
We
we
are.
had to get we had to get the slip up out of the way, so we're back,
All
right?
right.
So what exactly is a biomarker? This is a molecule found in either the blood or the other body's fluids as well as tissue that shows the signs of like a normal or an abnormal process of a condition or a disease. So basically, we use biomarkers to see how well the body responds to a treatment for a disease or condition, and this can also be called a molecular marker or signature molecule. And so there will be a lot of things that be thrown around that can actually mean the same thing, but we're going to stick with biomarker today. Test. Can you see the next slide?
Yes.
Perfect. All right. So why does this matter? Why do we need to know about biomarkers? This happens because after a diagnosis, you may be able to get more tests to help you decide on your treatment options and even predict your risk for reoccurrence. That means the cancer coming back. And so these genomic assays, I'm going to throw that word around a lot. These genomic assays look at these biomarkers to assess risk of reoccurrence, as well as to look at the activity of groups and genes in cancers to determine how likely a cancer is to either come back or respond to treatment. So if you want to know if a drug is actually going to work, a biomarker can be a good way to denote that. And so these assays, these genomic assays, are also known as tumor biomarker tests. And so when you go to the doctor and they ask, "Hey, do you want a genomic assay?" You'll know exactly what they're talking about. They're talking about a biomarker test to see the differences within the cancer. So, as I mentioned, biomarkers are a way to look for differences within the cancer. I always like to give the example that I have two younger brothers, and when we were kids, my mom had to buy different cereals for all of us because we didn't eat the same thing. But she knew what we liked. She knew what worked best. She knew what would keep the kid quiet, right? So that's exact kind of thing with cancer. Cancer is different for everybody. And so when we look at biomarkers, we're able to understand the differences in each person's cancer individually. What therapy might work for one patient may not work for another patient. So we need to understand the differences between this cancer. And now with technology and new advances in research, we're able to practice precision medicine. I'll talk about that later in the talk. But this is a way to individualize treatment for cancer patients. And so this testing may be able to help doctors choose a cancer treatment that's right for you and only you, as opposed to a one size fits all approach. So we're in a breast cancer talk, and so let's talk about biomarkers that are important in breast cancer. We hear the words ER, or the terms ER, PR, and HER2 thrown around, but what exactly does that mean? ER stands for estrogen receptor. PR stands for progesterone receptor, and HER2 stands for human epidermal growth factor receptor 2. And so these are all biomarkers that are really, really important when we're looking at breast cancer because there are certain therapies and certain treatments and certain medicines that work for patients who have either one of these, both of these, or now we see that specifically a patient can have none of these, and this is called triple negative breast cancer. Triple negative meaning all three of these are not present in that patient's tumor. And so Black women have a higher incidence of triple negative breast cancer. So this is really important to understand if these biomarkers are present within this patient's breast cancer. On the flip side of that, we have two other genes that are really, really important, BRCA1 and BRCA2. So these are genes that denote hereditary risk for breast cancer. I'll give a common example of a celebrity, Angelina Jolie, had the BRCA genes and she got a double mastectomy, right? She got both of her breasts cut off because she knew that she had these genes that were inherited. And so these types of genes, we call these germline mutations, right? Germline variants. Germline meaning it comes from our mom, our dad, the egg and sperm, and we're inheriting this from our parents. And so these are genes that we really want to focus on when we're thinking about breast cancer, because it's really important, because there's also therapies that can work for patients with these mutations, with these genes that happen to be mutated. And also, when we think about biomarkers, we talk about these, these hormone receptors. We talk about BRCA1 and BRCA2, but there's also therapies such as immunotherapies that can be really, really beneficial. But we need to understand the biomarkers within the cancer to see if a patient will benefit from that. And so we'll dive into that for just a second. So when we talk about immunotherapy basically is using our body's own defense to fight cancer. When we get a cold, even when we get COVID, right? So I'll use COVID as an example. Is the newer infection. We're sometimes we stay at home, and sometimes we have medicines that help work for that. But when we're staying at home, we have no medicine. They kind of tell us to kind of fight it off. So that's our body fighting it off, right? And so now, with recent advances in research and therapies, we're able to harness our body's own cells to really fight cancer on its own. And so that is what immunotherapy is. And so we have some signatures that we look at to note if a patient will benefit from immunotherapy. Number one is tumor mutational burden. This is defined as the number of non-inheriting mutations within the cancer. So the more mutations that are in that cancer, the more genes that are messed up. I'm going to start talking really kind of without the science. So the more genes that are messed up within the cancer that may help a patient benefit from immunotherapy. The next part is microsatellite instability. Basically, this means that the DNA within the cancer is stuttering instead of making sense. Normally, the DNA is speaking fluidly like I am right now. But with MSI, this means the DNA is kind of stuttering. So it really doesn't make sense. And so it makes it really, really difficult. And so this can be a signature for immunotherapy as well. The last one is what you'll commonly hear a lot is PD-L1, right? PD-L1 is another immunotherapy signature. This is a protein that acts kind of like a brake on a brake to keep their body's immune response under control. So usually there's another part called PD-1. And so when PD-1 and PD-L1, when they bind, this stops those T cells from actually killing the cancer. And T cells are a type of white blood cells that fight infection, even cancer. But there are therapies now that can block that binding, right? And so when that binding is blocked, then you're able to allow those T cells to be released and actually fight the cancer. And so if we're doing biomarker testing to pick up this signature, we know that patients have this marker. We know that patients will benefit from that therapy that blocks that binding, that releases those cells to kill the cancer. And so this is a really important signature. And it's also important to note that not every patient is going to respond the same way to immunotherapy. And so biomarker testing is a way to weed out and kind of understand which patients may benefit the most. And so I've talked a lot about biomarker testing. So how exactly is it done? We do this two different ways. Number one, we can use the tissue test. So that's actually getting a piece of the cancer off and sending it in for testing. Or we can do a liquid biopsy or a blood draw, right? And so these things, when we look at the DNA and we analyze it, we run the tests, I call this the results that we get a cancer report card. And so on that cancer report card, it has all the things that you need to know about that patient on an individual level, based on their own type of cancer. So this is not my cancer, my brother's cancer, my aunt's cancer. This is specifically for you. And on that cancer report card, it'll tell us, hey, this patient may benefit from immunotherapy. Hey, this patient may benefit from a PARP inhibitor because of those BRCA alterations. And so understanding this, I wanted to kind of paint the picture of actually how do we get the testing done? How do we find out about all these signatures, and why it's important to really speak up and understand that we need this done on all of our patients before they even begin testing. And so when you get the results, what does this mean, right? I mentioned this earlier that we can find out which therapies work best for which patients, right? And so when we get the result, we can figure out which therapies are targeted to that patient. There's things called resistance mutations. So resistance mean that a therapy is no longer working for you when we thought it would. So it's not working for you at all. So this can be really beneficial to know about a patient. This is also really important, is that sometimes no result is a great result, right? So these are results that are not actionable, or we find things called variants of unknown significance, meaning, right now we have no idea what it means, right? That doesn't mean that tomorrow a paper comes out or a clinical trial happened and it had that same mutation that that patient had, that's now going to pair them with a therapy. And so even though it doesn't work right now, it doesn't mean it's not going to work 5 months down the line, because that's exactly how fast the cancer research field is moving. And lastly, those germline mutations, those mutations that we inherit from our parents, being BRCA1 and BRCA2. So is this precision medicine? I mentioned that earlier. Now, before, everyone was kind of treated as a one-size-fits-all. Between chemotherapy, we call it a day. But now times have changed. Times have changed. And so you can actually go in, get your biomarker testing done, and you're treated in an entirely different way than someone else. And so this is the idea of this is not new, but now, because of all of the recent advances, there are tons of therapies now. I give an example. This is a breast cancer talk, but lung cancer is actually the poster child for all of this, because there's so many alterations within that particular cancer that you can target. There's so many drugs, right? We just need that to mirror in breast cancer, right? We need the exact same thing so that we can make advances in this as well. And I'll end here with barriers to testing. Why am I talking about this and why it's really important? Historically, Black people and Black women, Black men, are historically tested at a lower rate. We're historically screened at a lower rate. And these are things that are due to a plethora of reasons. So number one, disparities in access to testing reflect both systemic influences and patient preferences, financial barriers, historical healthcare system trends, which continue to influence how patient behavior. As a Black person, it's really hard to gain our trust. We go in already kind of side-eyeing a little bit, right? And that's okay, right? Sometimes a side eye is good because it's gonna prompt you to ask questions. And so I always tell people it's not a lack of trust that we have, is that you have to gain us, right? Someone gave the example yesterday. It's like, if I don't know you, I'm not gonna give you my wallet, right? But if you become my friend and a trusted source, I may let you hold it, right? And so building trust is really important in the Black community when it comes to understanding these types of testing in education. And lastly, unaware. That you will be amazed how many times I've talked to friends and family, and they had no idea that you can actually get tested for things that may help you, right? I still understand that cancer is still kind of an alien to people. We know it affects our families, we know it affects our loved ones, but we don't know exactly what it is. I'm here to tell you that with the proper education, and we have some patient advocates on the call, and honestly, they're the smartest people when it comes to these things, because they research this more than the people who actually do the work, because it's affecting them. So understanding that education is really, really important, and understanding all of these barriers historically have kept Black people from advancing in biomarker testing and screening, and how do we combat that? So Shonda, I'll stop there.
What a place to stop. That was great. Thank you, Henry, for that presentation with such a wealth of information. I literally was about to write, what are some ways that we can, combat that? And I guess we'll dive into that a little bit more as well as we continue on with our conversation. But yes, I invite you with such rich content. Please also, if you have questions related to Henry's presentation, I know I have written several for us to talk about as we continue on, to please do so. And I'm going to now, I'd love to introduce Dr. Nizar Bhulani, who will be also giving a presentation. Dr. Nizar is an investigator and senior scientist at the Dana-Farber Cancer Institute in the Division of Cancer Genetics and Prevention. He's a physician scientist and is focused on developing and delivering interventions to reduce the risk of cancer in high-risk individuals. His research involves conducting phase 1 to 3 clinical trials for evaluating novel agents for the treatment and prevention of breast cancer in women with the BRCA1, BRCA2, and other mutations. He currently serves also as a mentor for the American Society for Clinical Oncology Mentoring Program for young investigators, and is an ad hoc reviewer for over 7 journals, including the Clinical Oncology, Clinical Cancer Informatics. We are so delighted to have you here, Nizar, and we look forward to hearing more about your work.
Thank you so much. And Henry, great job. Thank you so much for bringing up all those important concepts. And hopefully I can follow up with a decent presentation. Can you all see my screen?
Yes, we can.
All right. So thank you again for the opportunity. Today, I'm very excited to talk about breast cancer prevention study, or the BRCA-P study. But before I talk about the clinical trial, I wanted to talk about some of the other things and just build upon what Henry mentioned. And I do not have any conflict of interest to report. So a little bit about the BRCA1 gene. Every cell in our body contains about 22,000 genes. These genes are made up of DNA, and they're mostly in pairs. That is, everyone has 2 copies of each. These genes, they contain instructions on how cells should behave. Why this is important? It's because one of those genes is the BRCA1 gene. The BRCA1 gene is an important part of the system our cells use to fix errors in the DNA. And in women who are born with a change or a mutation in one of their 2 copies of the BRCA1 gene, and only one of the genes is working, that is enough to keep the breast, ovary, and the pancreas cells behaving normally. But if something happens to the remaining copy, what happens is then the cell has no working BRCA1. And the cell can then begin to collect errors in the DNA, and once that happens, some cells will self-destruct, but others will become cancer cells. And because BRCA1 is so important in keeping normal cells healthy, BRCA1 gene is actually called a tumor suppressor gene. And one may ask, why all of this is important. And it is because about 1 in 400 women carry a BRCA mutation. Women who carry a faulty BRCA1 gene have a very high lifetime risk, up to 50 to 70% risk of developing breast cancer. Research has shown that BRCA1 mutations have a much higher chance of developing something that Henry mentioned about is a triple negative breast cancer, which is an aggressive form of breast cancer. It is very difficult to treat and does not respond to standard medications like tamoxifen that you've heard of. Another important thing I feel is triple negative breast cancer is most commonly found in young, Black, and Hispanic women. So of course, it really hits home for us. So how do we respond? Breast cancer, it is a formidable adversary that has touched the lives of countless individuals and their families. And I personally feel that it demands another approach, which is prevention. And it is a clinical aspect of addressing this widespread disease. And before we can make any meaningful progress, I think it is very important to approach this with work that prioritizes empathy, inclusiveness, and advanced scientific research. So currently, the only effective strategy for reducing an individual's with a BRCA1 mutation, their breast cancer risk, like Henry mentioned, was a prophylactic mastectomy, which is complete removal of both the breasts. It works well. It does reduce the risk by up to 90%, but I'm sure we all can appreciate that such a surgery can have both physical and emotional impacts. But if somebody does not wish to go through any of these surgeries, the usual approach for women who do not opt for any of the preventative measures is to be closely monitored by their doctor to watch for the development of breast cancer. And most recommendations include having an MRI and a mammogram 6 months apart every year. And while this does not actually reduce the risk of breast cancer, it can help detect breast cancer in an early stage when it is most curable. The other surgical approach is something that we call as a prophylactic bilateral salpingo-oophorectomy, which is removal of both the ovaries and the fallopian tubes. Earlier, it was believed that that such a surgery can help reduce the risk, but a recent reanalysis showed that it did not have any impact on reducing the risk of breast cancer in women who carry a BRCA1 mutation. Now, with all these challenges, we were very lucky to find out that one of our colleagues from Australia looked into ways to mitigate the risk using a drug that is called denosumab. Denosumab is a medication that has already been approved by the FDA for treating osteoporosis, which is weakening of the bones in healthy individuals. So somebody who has no other comorbidities. It is also approved for serious bone problems in people who have cancer that has spread to their bones. And so this was the basis of our work, where this pathway of rank ligand inhibition showed that that a normal cell would not move towards becoming a cancer cell, and this really helped us develop the BRCA-P study. The BRCA-P study, or the breast cancer prevention study, is an international research study for women who are born with a mutation or change in one of their BRCA1 genes. And our goal is to answer this question: that can the study medication denosumab decrease the risk of developing breast cancer compared to a placebo, which is an inactive substance, in women who carry a BRCA1 gene? I've thrown in a few technical terms like randomized and double blind. What it really means is that women who consent to join will be randomly assigned by the computer to receive either denosumab or the placebo as a small injection subcutaneously or under the skin, every 6 months for up to 5 years. And neither the women nor the staff would know which substance they are receiving, but they will receive the same substance for 5 years throughout the treatment phase. One of the good things about participation is that women will continue their careful screening, the ones that I mentioned, like the MRIs and the mammograms. So they will be receiving the drug and their regular care. But there is more to the study, and we are not just looking at its impact, denosumab's impact on breast cancer development, but we're also looking at its impact on breast health, on bone health, on hormonal health, on quality of life. And we're also trying to look for some excellent biomarkers, which are very important for surveillance and diagnosis, early diagnosis of breast cancer. Development of such a trial takes a village. And here is our excellent team, a global team of experts who are leading the primary trial and the sub-studies from across the world. Now, the most important question, at least for myself, is who can join the study? You may be eligible to participate in the BRCA-B study if you're a woman who has a confirmed BRCA1 mutation, aged between 25 to 55, not having a history of breast or ovarian cancer, are not pregnant or breastfeeding, because we do not have enough data on its impact on fetuses, and have not had a prophylactic mastectomy, which is the removal of breast tissue. We welcome and we hope all eligible women will consider joining our study, regardless of race, religion, color, or any other medical factor. It is truly your participation that will help us advance the latest breast cancer research for our future generations. You can get involved. You can learn about eligibility, about our active sites. We have more than 30 sites across the US. Like I said, it's an international study. The study is open in 7 countries right now. So we are moving ahead full speed, and we hope that you'll also consider. These are the fundings that we have received. So there's a high level of trust put in by our partners for the success of this trial. Just finally, I want to come and talk a little bit about the recruitment materials. We did develop many materials that were focused on partners, providers, and participants. So I would highly encourage anyone who's watching this or will watch this on YouTube later to actually go on our website, which is www.brcapstudy.org, and look at these materials. If there's any question that we can answer, I'd be more than happy to do so. Of course, it takes a village, like I said, and we are grateful for everyone's support in the NCI and the team at Tigerlily for giving us an opportunity. This is our contact information. And if you have any questions, please feel free to reach out. I just want to conclude my presentation by sharing my personal story and my encounter with breast cancer. So my personal journey into the realm of breast cancer began in 2012, when my mother was diagnosed with stage 4 breast cancer. She passed away just 3 months into the diagnosis. Witnessing her strength and resilience in the face of such adversity really ignited a deep passion within me to contribute to the fight against breast cancer. And it very soon became evident to me that prevention and early detection using science was really the key to saving lives and reducing the impact of this disease on families. And this this loss has been my impetus, and this is the reason of why I do what I do. I do understand that individuals may be very apprehensive when they're joining clinical trials for prevention, but our emphasis is on the significance of shared decision making in creating a safe space where individuals feel empowered to participate in studies and trust the expertise of the team members. And truly, if we are successful, our study could provide a new option to reduce breast cancer risk without surgeries for women and families. And I hope you will be a part of this journey for us. Thank you.
Thank you, Nizar. Thank you for that informative presentation and being able to also explain about this study, the reason behind it, and then not just the reason behind the study, but also your reason why. As we continue to build trust, it's so important to hear what fuels us as to behind some of the work that we do, and that intention behind that. So thank you for sharing that, and I'm looking forward to asking you some additional questions. I know we have a few in the chat about about the work that you're doing in this space. Now I would love to turn it over to our phenomenal patient experts. You heard about the background on biomarker testing. Henry gave a great presentation sharing about that. That was really informative. It broke down even some of these the subtypes. Nizar went down a little further, even from once you understand about some of these subtypes like BRCA1, these mutations, this is what knowing and identifying this, how that can be used for preventative measures, and how early prevention is so key with the study that they are currently doing, that Dana-Farber is currently doing in 30 different sites, as well as seven different countries, and working towards what we can do to prevent cancer in that specific subtype. So now I'd love to hear from those who have been directly impacted by these phenomenal patient experts and warriors. I would love to introduce and hand it over to Lashelle Scott to kick us off to share her story, and then I'll ask Brooklyn, and last but not least, Shardell to share her story as well. So Lashelle, welcome, and please tell us about yourself and share your story. Welcome.
Hi, my name is Lashelle Scott, and I'm in Houston, Texas. I am a stage 3 HER2 positive BRCA2 gene mutation cancer survivor thriver. I'm still in the middle of the process. I'm also a patient advocate and now a certified policymaker in the state of Texas. I spent this last session, 88th Texas legislative session, pushing for policy for breast cancer patients. And one of the bills, 989, was for biomarker testing, which in the state of Texas, in your medical insurance, is most likely not paid for, but now the governor has signed it into law, which will be going into effect September the 1st, that your insurance carrier has to provide you biomarker testing. So I'm excited about that. And I'm actually in the midst of going to get a biomarker test again next week because of some suspicious matter that have arrived on my CT scan. So thank you for having me.
Thank you, Lashelle, and thank you for being here. I just had one question too. I just wanted to ask if you could expound on a little bit too. Is when you mentioned you're going for your biomarker testing next week. Which process did you have? I know Henry mentioned 3 different ones in order to get a biomarker test. Which ones have you experienced?
I had the original, the tumor biopsy, but this time they're doing blood. They're going back into the space where I had, they're looking at a suspicious space where I had some lymph nodes removed. And because I haven't received like a NET report yet, they're concerned about something that came up on one of my CT scans. So they're sending me back to check my markers and find out what's really going on, because I had Kadcyla. I had 16 cycles of it, and apparently I didn't respond to, it's not responding too great to me, for me. So we have to kind of start back over again, so to speak.
And that's the role that this test, the biomarker testing, does, is helping you for them to be able to go back and determine what, where to start. Okay. All right, thank you so much. And if you all have questions for Lashelle, I know that please write them as well into the chat. I know people, I'm sure, want to know and hear more about how you turned your patient advocacy, not just sharing your story, your voice, but also taking that to your state, the state level and that path, and how you were able to sort of push for pushing to working on that biomarker bill in Texas. Well, I think we have like a minute or so left. So could you be able to just sort of explain a little bit more about that biomarker bill and how you went about, leading your voice, lending your voice to that conversation, and how others can do the same?
Well, I originally wrote a bill, I call the Breast Cancer Wellness Expansion Act, but there were some things that I didn't include in the bill because I felt like I wouldn't get it to the finish line. But in the midst of the session, someone said, hey, do you know about this particular bill that this has been submitted? And I think considering your type of cancer, you should, go tell your story. So I wrote comments and I spoke out about how important it is about biomarker testing, because in the beginning, of all of this, no one really talked to me about this. And you're fed so much information at the beginning of your diagnosis. You don't know what to think. You get a pathology report and it's like, what does this mean? And you're just thinking about, I just want to get through this. Now I'm on this side of the spectrum. I just took that position on, okay, if I gotta fight this, then I gotta fight for me. And if I can't help myself, I want to help the next woman coming along with breast cancer, especially in Black and Brown communities. And here in Texas, the rate of death for Black women, breast cancer is really high. It's right after infant mortality rates, and no one's really talking about that aspect. So for me, it was very important to speak out this session.
Thanks, Lashelle. Thank you for that. And this is also just to show how your voice can make a difference and being able to speak up for speaking up. I know there's a question in the chat about which genomic assay did you use on your tumor?
I don't know what that is per se.
Okay.
So
Okay.
I just know that I had a biopsy where they originally, when I first started out, and they took samples of the tumor along with some lymph nodes, and they determined what they were going to do and how we're going to try to cure the cancer. Well, now let's say that I have this plan and everything is supposed to be great. I've had a partial mastectomy, and now we're here like in 2023, and I'm still fighting, but they can't figure out why the Kadcyla really didn't work for me, or why am I still, having my reports are not coming back, like I'm not disease free, something else is wrong. And I actually had a checkup 2 weeks ago, and my doctor was suspicious on the back of my, because I can't see back there on my back arm, and because they've cut into it. She said, do you know that you're swollen and bruised back on your back arm? And I was like, no. She said, well, and it hurts. It really hurts. And so she said, I feel something. I think we need to see what's going on. I want to get your tumors marked. I want to get your tumor markers checked. And I want you to get a mammogram in that area. Because I didn't know that you could have a reoccurrence in the same area, because they really don't tell you all these things. So I'm learning all these things on the fly, and I'm trying to pay attention to what she's saying so I don't pass out. And so I said, well, what does it mean? So I have to go back and next week and get my blood drawn. So I don't know how long it takes. I know I've had blood taken the week before for something else, but I think it's different. I know it's a lot different from a regular blood draw. So this will be my first time having like a liquid biopsy.
Yeah, Shonda, if I can comment on that really quickly.
Yeah.
And thank you, Lashelle, for sharing that. So I think one of the questions was, which genomic assay did you use in your tumor? So that can come from two different ways. You can think about tissue tests, which is actually getting a slice of the cancer and then send it in for analysis, or the actual blood draw. Or that can be which company did you use? That's a whole nother conversation. But what she's mentioned is that she used a liquid biopsy to kind of do another test. In that liquid biopsy, I mentioned this in the chat, the tumor sheds off little hairs. This is what I call it, right? So I give the example of I have two dogs, and they shed everywhere. So if they go in the living room, I know where they've been because the hair is there, right? So that's exactly what we're doing with the liquid biopsy. If the tumors, if they're active, you'll get a lot of those cells within that test. So we can know that it's doing something, right? And when we think about that, you're probably looking at things like, hey, is this cancer probably going to metastasize? That means spreading to the other part of the body. And so in liquid biopsies, we're looking at these things called circulating tumor cells, right? We have tons of cells in our body, but this particular assay is looking at the cells that come exactly from the cancer as opposed to a normal cell. And so that is what a liquid biopsy is. And that is what Lashelle was mentioning.
Thank you for breaking that down. And just, yeah, now I understand. This is why it's so good to, like you said, just being able to break it down and put it in those terms is very helpful. So I hope that helped those who are listening in as well. Lashelle, did you want to add something to that?
No, thank you, Henry, for clarifying that to me as well, because you go when you go to the doctor and they start rattling off all these things and you're just like, oh my God, you're trying not to panic, you're trying to take notes, you're trying to remember everything, you just know you got to get this done. But because this bill has been signed into law and it won't go into effect to September the 1st, I will have to pay for this liquid biopsy because my insurance won't cover it yet.
Which is something I definitely want us to get back to. And that's one of the questions I had too, is the cost about this. I know Henry mentioned it a little bit, but when you talk about these different, like you said, liquid biopsy, these different, like how, the coverage, how is that covered? Like you're saying, I mean, you're still going through treatment, but this is something that isn't covered. So now you're gonna have to pay, even though it's something that you need in order to understand next steps, but it has to be you're having to pay out of pocket for this, which is what I mean, this is a critical component for you to be able to move forward in your treatment. So it should be something that's covered. So it's, yeah, I know you're like, Shonda, I know, I can see you're like, yes, period. So I wanted
this is why I advocate and fight in Texas.
Yeah. This is it right here.
Right here.
Yes, thank you, Lashelle. Thank you so much for sharing your story and answering some of these questions. And I'm sure as well, like I mentioned, if you all have additional questions for Lashelle or even comments, please put them in the chat so we can get to them. I'm going to now turn it over. We're still going to keep it in Texas. We're going to keep it in Houston. We're just moving over to Brooklyn, who is also currently in Texas, to share her story and about her journey. Welcome, Brooklyn.
Hi, everyone. My name is Brooklyn, and I was actually diagnosed with stage 1B breast cancer 4 days before the pandemic was declared in March of 2020. So things were a little bit crazy on my ride. I'm also BRCA2 positive, and my story with biomarker testing starts with finding out that I had the BRCA2 mutation. It's so interesting, and I'm so passionate about this because you truly don't know what you don't know. I have a twin sister, and she found out that she had the BRCA2 mutation just by going in. She was searching for a Black gynecologist, and she had found one. And like everybody else, filled out that intake form and had marked, we had only had one aunt that had breast cancer. And she put that down on her intake form. I don't know about you all, but I've never been asked about my family history on an intake form. So when she went in, the gynecologist first started with, oh, I noticed that you had an aunt that had breast cancer. You would actually be someone that I would consider genetic testing for. No one has ever suggested that to myself. I've never even heard of it at the time. And so she said, okay. And it was a saliva test. It wasn't covered by insurance. So she paid a few $100s out of pocket. Came back, she found out that she had the mutation. So then that started a whole surveillance program for her. So I, at the time, had just graduated from college and I was in this postgraduate program. I went to my gynecologist, who had never suggested it. And I said, hey, I want to get this biomarker testing done too. I have a twin sister and she's BRCA2 positive. Insurance still didn't cover it. So I waited a couple of years until I got my big girl job and was able to afford it. And so I found out at 25, but I essentially kind of knew my twin sister had it, very high suspicion. So at 25, that's when I started doing surveillance instead of doing the prophylactic mastectomy. And, you know, you're 25, you're young, you think you've got all the time in the world. I was having annual breast MRIs. 3 years later, at 28, is when I found out that I had cancer. And early detection truly saves lives. I wouldn't have had a mammogram until I was 40, just based off of guidelines. So I was so glad that I had had that testing done. Thankful for that doctor that pushed for my twin sister to have it so that I did it. I tell people all the time, I'm like, she saved my life. And so that kind of started my whole realm. Once I was diagnosed, I did the whole shebang, chemo, surgery. I ended up having biomarker testing on my tumors. And they found out that I was ER/PR positive, HER2 negative. And so that kind of was able to give me some personalized medicine and personalized approach for my treatment cycle. And currently, I am a big proponent of advocating on social media sites. So I use my platform to talk about breast cancer, especially with young women, genetic testing, biomarker testing, especially when it comes to Black and Brown, who, like you said, I liked how you phrased it, Henry, and you said, it's not that there's a lack of trust, you just have to gain our trust. And so I use my platform to really talk about that and how you can advocate for yourself to make yourself feel a little bit more comfortable when you're going in asking questions to the doctors, because it's so important to come armored with your questions. So I'm excited to be here. I'm super passionate about it. Like I said, ask me any questions about my journey. I'm an open book. And thank you so much, Shonda.
Thank you, Brooklyn. Thank you so much for being here and sharing about your journey and also your twin sister, just that whole process. And even especially the part, I know that hit for me too, when you were talking about getting your big girl job where you can actually cover and pay for those things. I asked for genetic testing from a Black OBGYN, and she said, no, because you aren't, like, you don't need to do that based off of your records and everything. So I had to go to someone else to finally like ask and change to be able to get that. So you're right, there is some, like, you have to really push for it, and also being able to see what's covered because of the cost of it. The first one was thrown out because I couldn't afford it. So, but it's so important to be able to find out different ways to be able to get that, because like you said, early prevention is so important, and you're able to get a lot of answers as a result of that. I know that we will, one of the questions that has been asked, or that we'll talk about too, relates to like your different choices. So you're saying, like, you're 25 and you chose at that time, you didn't, not to go ahead with getting, a mastectomy, but doing surveillance instead. And because you were continuing to do that surveillance, it helped you to be able to capture that early. I don't know if you wanted to talk a little bit about why you chose to wait and to do the surveillance instead of doing that mastectomy at the time. Does that make sense? Oh, I think we.
Now that I'm in the community, I feel like I have so much more knowledge about all of this, knowing what I know now, and it's hindsight 2020, right? Like, knowing what I know now, if I had went back and someone said, hey, you've got the BRCA2 mutation, this is what it means, I probably would have opted for the double mastectomy. But the conversation was very short. It was, you have this gene, it increases your risk of breast cancer in your lifetime, upwards of 60% for BRCA2, 80% for BRCA1. So, in my mind, I just was never thinking that.
Hello, Brooklyn? Oh, we lost her. Well, oh, there she is. She's back.
Oh, I'm back. I don't know if that was me. Okay, my apologies, everyone. I didn't even know I had popped out. Yeah, I think for me, knowing what I know now, so much more information than what I had at 25. When I found out, the conversation was very much, you've got this genetic mutation, there's BRCA1, BRCA2, BRCA1 increases breast cancer risk in lifetime upwards of 80%, 2 is upwards of 60%. And so in my mind, I just never thought that in my 20s, I was in the best shape of my life at that time. I was running every day, I ate very good. And I just never thought that that was something that would happen to me. They were like, you need to do it now. And I said, no, I'll wait. I'll have a couple kids down the line, and then I'll have my mastectomy, and the conversation kind of ended there. And then, I was referred to a genetic counselor, and they're like, well, the genetic counselor might talk to you about your options for surgery. And so I never even made the appointment for the genetic counselor, because in my mind, I was like, I already know I have the gene. Why do I need to see a genetic counselor? And the genetic counselor, I wish I'd gone to then, they can talk to you a little bit more in detail about your risk, the biomarker testing, what it truly means. And I don't know if it was that my gynecologist wasn't equipped to have that deeper level conversation, but I didn't feel like it was really sold to me, the importance of doing that. And so, they said, well, plan B, you can just do surveillance. My breasts are a little bit more dense. Being a young person, that's very common. So they said, instead of the mammogram, we're going to just have you do a breast MRI. So if something does pop up, we'll catch it early. So I'm like, okay, well, that's very proactive for me. I guess I'll just go with that. And what's crazy is, when they found the cancer when I was 28, they said it was confined to the milk duct, which they call DCIS. They said the cancer is just in your milk duct. You actually can just have surgery, and then you don't need to do chemo, radiation, or anything. And so I was like, okay, that's really not that bad. I'll just do that. But when they did the surgical pathology, so when I had my breast removed, they went in, took some tissue samples out. They actually said, they found 3 more small tumors. There was one that was 2 millimeters, 3 millimeters, and 5 millimeters. And then they saw some like lobular-like cancer, which is they said it's a little bit more trickier to find on imaging. So there were all these tumors that were in my breast that imaging didn't even pick up on. The doctor who read it, the radiologist, didn't even see those. So I'm like, oh my gosh, like it was there. No one even knew that it was there. And I had my surgery like shortly after my diagnosis, thank goodness. So I'm like, in my mind, they couldn't just all those came up that quickly. So, I was really grateful that I made the choices that I did with my treatment, because I think ultimately, like I said, like early detection truly saved me. And then just having doctors who were able to advocate for me until I was able to learn more and advocate for myself was a really important part of my care.
Thank you. Thank you, Brooklyn. Thank you for sharing about, there's so many questions I have too, and I'm sure others do as well, just from you providing and explaining about your journey and what you've gone through. And also, I think that's what's also important, is hearing these different stories and hearing your different experiences, some shared and some that are different in the same city. So Lashelle and Brooklyn are both in Houston, so sometimes it depends, or, those, like you said, having a team that you're able to speak to, that can advocate for you, and you had that experience. Lashelle, her experience has been different, where she's had to find a different oncologist, starting over and trying to go through that because of not having that advocacy. So I think it's also important to hear these different perspectives, as well as being able to see and understand, these different takeaways from that. So just thank you, Brooklyn, for sharing your story and for being here. We will be
Sure.
adding elements. Oh, yes. Go. Yes. Is that Nizar?
Yes. I just thank you, Brooklyn, for this story. I actually want to bring up 2 very important points that you raised. One is the fact that when your sister had the mutation, you also went ahead and got tested, and that is a very important concept, and that is cascade testing, which is a process of informing family members of a particular genetic condition which is discovered within the family, and it is followed up by family members getting tested for the same condition. And I think this is an extremely important thing, and anybody who can afford it, can have access to it, should get that done. And another thing that you mentioned about was that you weren't sure how you would get it. I mean, if, like Henry mentioned something about germline mutations, meaning that if my parent had a mutation in, for example, the BRCA1 gene, what that would do is it would increase my particular chance of getting this mutation by 50%. So there's a 50% chance that I can also have that mutation, and then there's a 50% chance that I would pass it on to my children. When my mother had breast cancer, we tested my sister and of course her daughters, but my sister came out to be negative. So it is not always possible that the offsprings or siblings would have this mutation, but there's a 50% chance that they would.
And that's so important. After my sister and I did, we did that. So we went to all of our siblings, even boys too, because a lot of people think that this is just a woman issue when it's not. And certain germline mutations like BRCA can increase risk in men for different cancers, prostate cancer being one. So my brothers are going to start prostate cancer screening earlier now because of this. And it was so unfortunate because I think in the Black and Brown communities, oftentimes we don't talk about our health problems and things like that until something comes up like this. So after I was diagnosed, I went to my parents and I said, hey, is there any other cancer in the family? And my dad was like, oh yeah, my sister, and then my other sister who passed away, and then like her aunt, my mom. And I'm like, why was this never shared? Why did I have to be diagnosed for me to find out my whole family history was full of cancer? And so I think we as a people just need to do more conversations with our families because it might not always be brought up just kind of out the blue on our own.
Yeah, speak on it. I was definitely snapping over here, Brooklyn, when you were saying that too. It's we don't find out until after the facts, or you bring it up, or you're like, hey, this happened. I came out from the doctor and they said this, and they're like, oh yeah, Auntie so and so, and you're like, y'all should have told me. Like, why did y'all tell me? So it's so great. I mean, it's important for us, at least we're learning too with our generation, to be able to have those conversations and being able to say like, hey, listen, this is why it's important for us to do that. And Nizar, you said that you mentioned a test, and I couldn't figure out like the way that to spell it, but you said there was the casket testing. What is that testing called? Where you said like, with the incident that happened with Brooklyn and her twin sister, that since her twin sister had this mutation, Brooklyn went and got that. What was that called again? If others wanted to do that.
Yeah, casket testing is a phenomenon where if someone finds out that there is a mutation within the family, then other family members also get tested for the same condition.
Okay. All right. Thank you. All right. And then now, and continue with the questions as well in the comments. Keep them coming, y'all. I'm going to pass it over we're taking it back from Houston. We're taking it to Charlotte, North Carolina, bringing it back to Shardell, who is going to be joining us and sharing with us about her journey, her story. Shardell, welcome. And we're so glad to have you here.
Thank you. Thank you for having me. Unlike the other two, I'm not from Houston. I'm from Akron, Ohio, but I am a Rolling Stone. Like Brooklyn, I was also diagnosed during COVID. But I'm BRCA1 positive, HER2 positive, ductal carcinoma, not into. But the difference is I knew my family history, and I actually found my lump. I found it, and I had just lost my job in March. And my first mammogram was at the age of 16 because my mother had breast cancer. Her mother passed from breast cancer, and I had some aunties and cousins that also passed from breast cancer. So I was always on alert to find and do my self checks. And then when I was 16, I had my first mammogram. Then when I went to college, I also had mammograms as well. So I was always aware that my risk was high because of my family history. So and I also had this breast, and the one breast that was always on alert was my right breast, which where I found the lump. So when they found it, they told me, I cried for like 5 seconds, where my eyes said, Lord, give me the strength. We got this. We're gonna get through this. My mother, the first time she was diagnosed, she did not have the BRCA test. The second time, she did. She was BRCA1 positive. I got the test done as well. I'm also BRCA1 positive. I wanted to get a double mastectomy my freshman year in college because I knew the history, but my mother didn't want me to because she said that had been too much for me at such a young age, and she also said it might skip a generation. So, and I'm not a parent, but she was right. It definitely would have been a lot physically and emotionally for me at that time. But went through all of that. I call it deluxe package when it comes to treatments, because any ectomy at the end of it I've had. hysterectomy, double mastectomy, oophorectomy. There's no reproduction. I don't have no reproduction, anything in me. Everything is gone. So, but when the presentations happened, and he said that the oophorectomy is, they saying that it proves that it has no, they're proving that it doesn't show that there have any proof that it does not protect against getting breast cancer or have an effect on it. Now it's making me think like, did I make the right decision in that? But because I'm BRCA1 positive, my chances of ovarian cancer increases. So I had to get the hysterectomy anyway. I didn't have to, but I decided to. So I knew my family history, and I think it's a very, very important topic to have because I was always on alert. So I knew about my chances, where some people didn't know, like Brooklyn was talking about. She didn't know about her family history until it happened. So I called it, and I was stage 2. So.
Thank you, Shardell. Thank you for sharing that. Oh, Nizar, I think you wanted to pop in too.
Yeah, thank you, Shardell, for sharing your story. It looks like you said you had a BRCA1 mutation, is that correct?
Yes.
Yes, and so those who have a BRCA1 mutation, like I mentioned, have up to a 70% chance of developing a triple negative breast cancer, and meaning that these cancers are not impacted by the hormone estrogen. And that's why a recent analysis showed that a bilateral salpingo-oophorectomy, which is removal of ovaries, does not help against protecting against breast cancer, but it does protect you against developing ovarian cancer. So I know you might be questioning your choices, but I think you did what was right for your health.
Thank
Thank
you.
you.
Yes, thank you, Nizar, for sharing that. And Shardell, thank you so much for sharing your story. I'm going to open it up to the audience. I know that there are several questions that we had as you all were talking and sharing. But since I see Rosalind's question popped up, I'm just going to open it up because I think it was actually, there are 2 questions that we had related to fertility planning. I think this was for Brooklyn, Shardell, and also Lashelle. Was that something that came up in conversation? And the fertility planning was the first question that was raised. So I'll ask that, and then I'll ask the second part, which is, because you were so young at the time of your deluxe package, again, did your oncologist discuss any fertility or family planning with you?
They did, however, and I didn't know there I had the whole everything removed. No one discussed how having chemo affects your AIDS. I learned that because I had one of the highest TCHP, which Taxotere, carboplatin, Herceptin, and Perjeta, and the main chemos are carboplatin and Taxotere. Your immature eggs, most of them, they're done. They won't develop, right? And your mature eggs, some of them probably won't make it. So I was told that after the fact. And what they ask you, and when you have an fertility discussion, is, do you want to take some of those eggs, fertilize them, and then we put them back in you, help them mature, and then we'll take them back out, and then have them mature again and put them back in you so you can give birth. For me, it became, I don't want to say pointless, but I couldn't give birth because I want to have a reproductive system, right? And then I didn't want to do a surrogacy because it became too much, mentally for me. So there's other ways I can have a family. So for me, it was to me. I'm sorry if I'm getting emotional. To me,
It's okay.
I just didn't want to do it.
It's okay. And Shardell, thank you for sharing about that too. And like you said, there are different ways and for holding space for you to be able, because it is something that's very emotional, to be able to talk about. And it's something that I know that we have had other different people who have been on who weren't even given an option or being able to talk about it. So it's, as you're sharing this, you're also touching somebody that's on this call or that'll be listening to this about their own journey too. So I just want to thank you for that, for opening up. I wanted to pass it to Lashelle and Brooklyn too, about your sharing a little bit more about that too.
I
Yeah.
wasn't, I'm sorry, I wasn't given an option. And only thing I remember I was asked was had I had any kids or any pregnancies in my past. That was it. And I didn't know there was such a thing as oncologist that deals with fertility. So I missed out on that conversation. And I mean, although I never thought about having kids, I feel like my choice was still taken away because I, may have decided to freeze my eggs. But, I have a niece, I have a nephew, I have a dog. So I know a baby won't close that hole. I mean, a dog and my niece and nephew won't close that hole. I do feel like something is missing, and I was upset to find out that that did exist, and I was not given that option.
Yeah. Brooklyn.
Yeah, so for me, the fertility specialist was the very first doctor that I saw in person. I got diagnosed, and then I had 3 days later was the appointment with the fertility specialist. And then that appointment, they said I had 4 days to decide if I was freezing eggs and embryos. So I was just still wrapping around the whole concept of, hey, you have cancer. And then telling my then boyfriend, now husband, but then boyfriend, like, hey, yeah, so do you want to freeze some embryos? Like, I was trying to juggle that conversation with also finding out that like thousands and thousands of dollars that it would cost to do egg preservation and embryo preservation. I made too much to qualify for any of the grants. They were like, oh yeah, we can help you with the meds, but still I was going to be out of pocket anywhere from like 5 to 10 grand just based off of like the cost of the whole procedure. And so financially, it was too much for me at that time. So I didn't end up doing it. And then I'm also, very glad actually looking back to hindsight 2020 again, because my tumors were like 98% ERPR positive. So then pumping my body with more hormones would have been potentially scary, and that could have impacted things as well. So I didn't do it. And they told me, they were like, if you don't do it, the chemo that you're on, there's 50-50 shot that your reproductive system will just be blown. Like you might not ever be able to have children. And through a lot of therapy, I've been able to make peace with that. And like you all were saying, like, being a parent and lots of nieces and nephews, all those things, like I've definitely made peace with it. We're still going to try natural family planning. I've seen so many people on the internet. I found people through social media platforms who were told they would never be able to have children and have been able to naturally conceive. So there is some hope there, but I'm also a realist. So potentially that might be something down in the lines that we might happen. But I just recently started seeing a high risk OB-GYN that I was referred to by my oncologist. So we're starting to have those conversations now with potentially, there's been some new data that came out that said you can actually safely get off your hormone therapy if you've been on it for a couple of years to consider family planning, and it doesn't impact 5-year recurrence rates. So I'm very hopeful for that data and more data in the future that comes out because it's kind of scary. One, even thinking about getting off your meds, your safety net, at least for me, to consider family planning when knowing mine were so strongly ERPR positive and the surge of hormones that can happen with pregnancy. So I'm wrapping my mind around all of those things, but keeping the door open if it happens for me.
Yes, absolutely. Thank you all so much for opening up and sharing about, this very sensitive but real topic as women, especially going through treatment, post-treatment, and being able to see what, like I think Brooklyn touched on something that's also really important is the mental health aspect, and being able to go to therapy, being able to have conversations and spaces to be able to talk about this and work through it, because this is something that, yeah, it's something that can, oh, sorry, I think that, Yeah, something that is so, it's something that is ongoing, an ongoing conversation. And as you continue on, even after going through treatment, that you still have to sort of face and discuss and think about. And I think one of the things that also, Brooke, I think you mentioned, was that you had about like Lashelle, it wasn't brought up to you. Brooklyn, you had about 4 days to make this huge decision. And I think one of the questions that came in the chat too was about um, those options, right? So if you have, let's say, the BRCA alterations, should double mastectomy be the first option? Like, is that something that you should, I guess want to just pose that out to, I guess, Henry and Nizar, your thoughts on that?
Yeah, I think I'll kind of pose this because Brooklyn mentioned earlier that she spoke with she had the option to speak with a genetic counselor. So genetic counselors, she threw that out there, but I want everyone to know that genetic counselors are really specialized in these types of things, right? Understanding mutations, understanding genes and how they affect our health and how they affect the advancement of disease. And so historically, we see that most times, and this is like, I can pop the paper in there, but physicians, they recommend genetic counselor at a lower rate to Black women than they do white women. And that's absurd, but that's really important to consider, because when it comes to alterations like BRCA1 and BRCA2, and especially things that are inherited from our families, they impact families in different ways. But genetic counselors are really specialized to understand how these alterations, work in an advancement of disease. And so when things like that, when you understand that you have a BRCA1 and BRCA2 alteration, the first thing you should consider, if this is from a historical family like inheritance, talk to a genetic counselor. And if your provider does not, offer that, ask for it, because that is your privilege to ask for that, expertise. Because when you go into an oncologist, most times, if it's a general oncologist, they're specializing in pretty much everything. They're trying to balance, lung cancer, breast cancer, prostate cancer, all at one time. And so their minds are all over the place. But it's up to us as U.S. patients and people with family histories of cancers to understand that you have the choice and the duty to advocate for yourself. And so that's one of the things I always speak to my family and friends about is, if you have something that you don't leave the doctor's office until all of your questions are answered. And if they can't answer it, they need to refer to you somewhere else who can answer it. And also, you're not married to a physician. You can shop around. It's just like Target. You go, you find the right thing that works for you. And so until all of your questions are answered and you feel secure to make the decisions that you need to make the decision for your health, I think that's what's most important. Nizar, I know you came off of mute, so I don't know if you had anything to say.
No, I think I completely echo what you mentioned. Talking to a genetic counselor is very, very important. And it's a very specialized field. Like here at Dana-Farber, we have a Center for Cancer Genetics and Prevention, because we want to look at genetics as a way of understanding disease, and also to try and see what modalities we can share for cancer prevention. Shanda, you mentioned something about a mastectomy. Yes, women who have a BRCA1 mutation, they have opted for a prophylactic bilateral mastectomy, because the results are so positive, right? I mean, it reduces your risk significantly, technically, because you're removing all the tissue from the breast. So if there is no breast tissue, there is a very low chance of you developing a breast cancer. But of course, trials like BRCA-P are there to provide non-surgical interventions. And if somebody who does not wish to go through this sort of a surgery, then certainly we need to have other options that are interventions. Well, you're not just sitting and not doing anything about your mutation, but you're actively trying to intervene and reduce your risk non-surgically.
Yeah, thank you for both Nizar and Henry for those explanations to that question. Actually, Nizar, there was a question in the chat, as you brought up, about the BRCA-P study, and it was a comment and question. It said from one of our audience members, I've heard from the women of color who are breast cancer patients that they are hesitant to sign up for trials if they have access, because they are afraid that they will receive the placebo and did not want to go through that for nothing. I also heard that because data is needed from women of color in clinical trials, that they will not receive a placebo because this data is essential for research and a cure. Have you also heard this?
I'm sorry that you've heard this, because I believe this is not true. these are randomized trials, at least the ones that we are running. And so, like I mentioned during my presentation, these randomizations happen truly in a random fashion through a computer. We have absolutely no control over who gets to be in the active drug arm or in the placebo arm. And this is what I said is a double-blind study, meaning that if you are unaware of your group of denosumab or placebo, so are we. So we are absolutely blinded, and so is the pharmacy. So there is no way that someone would know what arm you are being randomized to. So everybody has an equal chance of either getting a denosumab or the placebo.
Thank you for that. And follow-up question. I see Henry is about to add on to that too. Yes. So Rosalind's question is this for all trials or just for yours, this double blind? And that was my question too. Is it like when you look up a trial, is it something that's easy? You know, like for instance, when you, like if you know something is gluten-free or vegan, it has a little symbol and it's really easy for you to know. Is that something that, is it that easy as well?
Right. So let me break it down. So if a trial is randomized, then it is truly your designation is truly random. So either you get the drug or you get the placebo. So that part is controlled by the computer. But then there are some study designs where your assignment is open. For example, there's another phase 2 trial that we're leading here at Dana-Farber for reduction of breast cancer risk in women who have a BRCA2 mutations. And then there are those that are for non-BRCA mutations. So in that, we have just one arm that we are going to give the drug to the participant, and then the other group would be waitlisted. So everybody knows what drug they're getting, and if they're being waitlisted, then they know that they're not, of course, in the active assignment arm. And then at the end of the 6 months, these women have an option to take the drug as well for another 6 months if they want to do that. So if there is information that is available to you, or it is available to us, we try to be as transparent as we can be. And yes, I see a question. So randomized means you may receive the placebo. Yes, there's a 50% chance that you may receive the placebo.
And also, I really want to point out that placebo does not mean you're not getting anything at all. So when you think about placebo, I don't want to, people think, I know that the term is thrown around sugar pill, like they're not giving me anything, they're just gonna let me die. That is not true. Usually it's standard of care, and Nizar, like, please correct me with that, but you're getting standard of care. So I like to kind of paint the picture. This is not my analogy, this is from Dr. Keith Crawford, but when you're in a clinical trial, you're getting ice cream, you're getting some nuts on the ice cream, you're getting some whipped cream on top, right? That's standard of care. The actual treatment, the drug that we want to see if it's working in that population, is you're getting all of that, ice cream, the nuts, the whipped cream, but you're getting a cherry on top, right? So you're getting that drug that we think will work. And so we need to understand within that trial if this drug is going to be beneficial. It's also important to note that we need more Black people in trials, period. When we think about all the drugs now, most of those drugs are coming off approval were in trials where there were more than 90% non-Black, right? But we need these trials to represent the communities that we live in so that we can, understand the differences between our makeups to make sure that the drug actually works for everyone. And so if there's not diversification in trials, there won't be a likelihood where this drug may work for everyone, which is what we want to happen. And so that's really important. I wanted to throw that. Yeah, so you will be getting treated. You won't not be getting treated in the trial. And also, yeah, so another thing I want to point out is, like, when you're in a clinical trial, you're getting the best care. So they're watching you like a hawk. And so you're going to be followed, you're going to be studied, you're going to be, checked in a lot. And so these are things that you shouldn't be weary of. But although I do understand historical context, but it also is a part of us as scientists, as clinicians, to really explain the efficacy of clinical trials and why they're really important.
Yeah.
I think also, like, I remember when I was going through treatment, not a single doctor asked me, hey, do you want to be in a clinical trial? And I think a lot of times we think of clinical trials as a last line option and not something that should be a part of, like, first line as just general part of your care. And so me just being in the healthcare space, I had asked, during chemo, I just wasn't at a place. I was just trying to make it. But once I got to the radiation point towards the end, I asked my radiation oncologist, hey, do you know of any clinical trials? I'd love to participate in one. And then he was like, oh, actually, we have someone who works with people with clinical trials, like a nurse navigator. So I met with her and got enrolled in a clinical trial myself. And, going back to what I was saying, like, you don't know what you don't know. You don't even know to ask about this if, no one is telling you that this is something that's important. And I remember having so much pushback from my family saying, oh, same thing as you were saying, Henry, why do you want to be in a clinical trial? And like, they could be experimenting on you and all these things. And I remember asking my mom, she takes a cholesterol pill every day. And I said, the cholesterol pill you take every day, that went through a clinical trial at one point. If your doctor told you before you started taking it, we've tested this drug and we've actually only tested it on white women, but we want to give this drug to you. Would you feel comfortable taking it? And she was like, well, no. And I'm like, okay, well, like, that's why we need to be in clinical trials, so that the medications and the treatments that we're getting have actually been experimented and tested on people that look like us. So it's so important. And most offices, I do know, have some type of nurse navigator or someone that can help connect you to clinical trials. So just knowing to ask those questions, I think, is really important.
So Shanda, can I add something to that?
Yeah, and then I know Shardell also wanted to add something too.
Actually, I'll wait for Shardell. Shardell, please go ahead.
Yeah.
I was opposite of Brooklyn. I was offered to do a clinical trial, but it was during radiation. I actually didn't feel comfortable doing it because I was not. I didn't feel informed enough to do it, because they were going to give me actually more radiation, but in a less amount of time, to see how my body would take it, and I didn't feel comfortable with that. But they did approach me about it, and my mother actually, she wanted me to do it because, like Brooklyn said, she said if they don't know, how would they know it's going to work if we don't do it? So I didn't do it, but my mother, she was a big fan of it. But now that I'm more informed, if I could change things to go back, I would have done it.
Thanks, Shardell, for sharing that perspective too. Yeah, I know Nizar and then Lashelle also wanted to share something. Yeah.
No, Lashelle is our real hero. I think you should go ahead first.
Yes.
I'll wait.
Yeah. Okay. Lashelle.
I know in my first oncologist, I wasn't offered any information about clinical trials. And that was one of the deciding points that I wasn't getting a good standard of care, because when I began to question her about clinical trials, she became combative and just kind of gave me all this attitude and just kind of left me in the waiting room, in the room by myself for like 30 minutes. I thought she was coming back. Every question I asked about clinical trials, no, there's nothing for you. There's nothing for you. But I'm like, how are you know? How do you sure? Have you checked? And my second oncologist, she actually told me the same thing, that there's nothing for me. But I'm thinking like, okay, all this time, there is nothing out there, no clinical trial that I can participate in that would maybe not help me per se, but help someone else. So for me, I just feel like when I've asked the question, it's been pushed back.
Nizar, I don't know if you wanted to chime into that or anything based off.
Absolutely. So there's a lot of things that were said, and I just want to address some of those. I think what every one of you said is absolutely relevant. If you are not offered a clinical trial, please ask. And if your healthcare provider does not know about it, that's not the end of it. Look for it. And I think that is where advocacy organizations like Tigerlily are so important, because they are not just advocating, but they're also educating. And I think that's so important. And that's why I'm here to talk about a clinical trial, which you probably didn't know about before this call, right? So it has to be these sort of platforms that Tigerlily is providing. And we're so grateful to you all that you're giving us an opportunity to talk about these clinical trials. A lot of scientific work goes into developing such a trial, but I think my real education was when I was promoting the trial. We write all this stuff. We call ourselves physician scientists, and we're writing everything up for the scientific audience, but we really need to tone it down for the general population, for the general audience. And what we really did for our trial materials was I basically gave it to all the patient advocates that we were working with. I was like, tell me what you want to fix in this. The language, the appearance, the colors, the text, the font size, everything has to appeal to our prospective participants. And if it is satisfying me, that's not enough. It has to satisfy the actual people that we are trying to serve. So you are the ones that we are all working for. So if you ask questions, reach out to a local advocacy organization, to a national one like Tigerlily, find out about clinical trials. There's so much that's happening in this area. And like you said, when you are part of a clinical trial, like you are, for example, for BRCA-P, there is no way that I or anybody would know if you're receiving the placebo or not. You are still going to continue to receive the standard of care. You are going to continue to receive the mammograms, the MRIs, the regular testings that you would generally go through. And of course, we do understand that we are testing a new drug to find out. We're not even sure right now that if this drug is going to reduce the risk or not. This is a trial, this is a test, and it happens to have two arms. One is the active drug and the other is the placebo arm. But what is the benefit of joining such a study is that you will be actively being followed by a group of experts who have spent a lot of time in breast cancer prevention. And so, for example, in the BRCA-P study, yes, you will get the mammograms and the MRIs, but then there's a sub-study which is looking at breast density. There's a sub-study which is looking at bone health. A new technology has come out. It's called the Extreme CT scan. And what it does is basically looks at the bone microarchitecture. And so it is a very important thing for us to learn the impact of this drug on bone health. And then there are biomarkers that are going to be developed regardless of the arm that you are in. So I think for us to think that if we are going to get the active drug or not, I think we should probably start thinking about, which I'm sure you all do, think about the future generations. If we participate in trials, we would be able to provide answers for the future generations. And that is, truly been the spirit for everyone who's joined our trials so far and everyone who continues to join and will join in the future. So I'm just so grateful that there are people out there who are willing to join and trust us. And we will do everything to make sure that you remain safe and you get the best care that's possible.
Yeah, thank you. Thank you for that, Nizar, and for explaining that and just, going through the process. It's so great to have these spaces to be able to have these conversations and ask those questions. I know that we are over time, but I wanted to just ask like two other questions and we will, sort of wrap it up. The questions were, it was from in the chat too, do you have to have cancer to have biomarker done? Was the question.
Generally speaking, you don't have to have cancer to get biomarker testing done. In the context of cancer, it's important to get it done to understand how to best treat you on an individual level. And then also what's been echoed throughout the talk is understanding your family history of cancer and understanding if you need to get tested for BRCA genes to run that subject. So big answer, no, you can do whatever you want. In the context of cancer, though, it's important to understand what molecular markers that you have within your type of cancer, they may help fit the best treatment for you, if that makes sense.
And just to add to that, it also, Henry, I think you're right, but I think also to mention that what is that biomarker for? Is it for diagnosis? Is it for surveillance? Or is it for screening, right? So if somebody hasn't had cancer, that biomarker is for screening. If they've already had one and we're looking at just a progression of it, then there's surveillance. And some of the biomarkers are for diagnosing the disease. So depends on what biomarker we're looking for. We do not have a lot of biomarkers for cancer detection, but we do have some for cancer surveillance. And yeah.
Thank you.
Thank you. That was a good compliment. Thank you for that.
That was gonna be my next question was how do you know if you're asking for it, which test do you know? Because you all mentioned like different ones. So as for a layperson who isn't familiar with that and they want to get that testing and they, may not have cancer. So you answer that question to me as well, Nizar, about you can ask for like biomarker testing for screening purposes. You can ask for these. So those are also really helpful tips that you all have shared.
Yeah, and I'll just give an example. He talked about screening. I'm only 32, but I did prostate cancer screening because it's so prevalent in my family. I asked for it and they didn't cover it because I was too young, but I still paid the $100 to get it done. I just want to know what it was, because I know the age for Black men is now it's 40. And so that's coming up soon for me. And so, well, in about 7 years, but still, I want to make sure I'm ahead of that. And so screening is really, really important when you're thinking about biomarker and getting testing done too. So thank you, Nizar, for that.
Thank you all.
Can I say one quick thing
yes,
too? I know we're wrapping up.
Yeah.
I just want, because I've talked about this on my Instagram page too. A lot of people will use some of those things out there like 23andMe and those ancestry things. And they'll say, oh, I tested that and I'm negative for BRCA mutation, for example. But those things, they don't test for all of the different variants. Like it's not just one BRCA mutation, like there's multiple variants, thousands of them. And so if you're using things like that, you might miss it. You could actually have like a false negative. So go through your doctors, your gynecologist, your primary care doctor, and have like approved testing instead of doing like some of those online ones, because they could actually miss something. Just wanted to throw that out there.
So good. Thank you for that. That was like right on it, because people are like, I've heard it too, definitely, about like, I don't need to do that because I already, have gone on there and done it. So thank you for adding that in. Thank you all for participating in this incredibly informative conversation, for creating space for being able to be vulnerable, sharing your whys, sharing about your family health histories. Everyone, on here has shared in some way about what their experiences have been and how to be your own advocate, how to speak up, and share your voice, lend your voice to ensuring that the importance of biomarker testing, ensuring that others have access and coverage for it, which is really important based off of where you live. Also, through the importance of clinical trials and clinical studies, why we need to have our voices in those spaces, because that we can know about some of the side effects, or how it works and how it's beneficial to within our community. But if we aren't a part of it, then that part isn't covered, and we may be getting something that may not be the best fit for us as we look for that individualized care and treatment that's coming. So, I invite you to participate in those trials, or ask questions. Most of all, I love what Henry said about it's like shop around like Target, because we're quick to go there and find some stuff and go browsing. So we should have that same kind of energy. And I commend you and commend those who have been on the call, commending Lashelle for saying no, like this is not working for me. You are not giving me what I need at this moment, and I need to go somewhere else to find it. Someone who can ask those questions. And thank you to Shardell for sharing about your journey and family health history, and how that also helped with prevention and being able to come up making informed decisions, but having the options to have those decisions based off of knowing that family health history. And Brooklyn too, talking again about that family connection and being able to find out and understand about detection based off of your sister and what she's gone through, but based off of her results as well. So thank you, each and every one of you, for creating space, and to our audience as well for being here. A huge thank you to Henry and Nizar for your perspectives and your purpose and intention in the work that y'all are doing, and being a voice in this space, because we need you all here in these spaces to be able to be a voice for us, to advocate, to be able to explain, because you've been there, because you have a loved one who has been impacted by the cancer, to be able to say this is what we need to do and be that voice for us in those rooms. So thank you for your representation, because we need you all there. Keep it up, because each and every person on here and those who are going to be watching are the better because of you all being there. So thank you. It matters. You all matter. And let's just continue to lift one another up and support each other. We will be sharing some of the slides, because I know that was requested after, and there were additional questions. Most of them are mine, but I'm still going to ask them anyway to Nizar and Henry, and we'll share that with all those who have already responded. I know that I did ask Denisha to drop in the chat the handles for everybody so that you can follow them online, and we'll also put that in the recap document that we'll be sharing, so you all can contact these individuals, phenomenal participants, and I hope you all have a blessed, safe weekend. Happy early Juneteenth to you all. And thank you again for your time and space, for holding space for all of us. So thank you, and bye-bye.
Bye.